Now we move on to the trauma unit in our EMT course. This is lesson number 6 in the overall course, and this lesson is on extremity injuries. Probably take you an hour or so initially on this, and then there'll be some repeat work needed as you go back to your flashcards and you do some memorization and recall work on various bones and such. And we'll spend a couple hours in the lab, most of that consumed with injury management. The content is some background on musculoskeletal system, its function, the various parts and anatomy of extremities, and then assessment management of extremity injuries. So the musculoskeletal system's function is that it supports movement and posture. It allows for protection of internal structures, and that it has numerous other functions, one of them being that musculoskeletal system generates body heat. But if you were to think of it allows for protection, movement, and posture, that'd be a pretty good understanding of what we're talking about. Now, there's lots and lots of bones in the body. There's 206 bones in the body. You don't need to know 206 bones in the body. You need to know these bones in the body. So you're going to want to go back to this slide over and over. And we'll give you diagrams of skeletons, and we will put Post-it notes on each other, and we'll have you feeling on each other and feeling on yourself and saying, I'm touching my scapula now. And we'll work our way through all this. And so you should get going. You should start on this. But nobody expects you to be able to know all of these bones when you walk into the next lab. So part of the readiness check is that you know some of the big ones, but we need to start making progress on this. So cranium, maxilla, and mandible, the 5 divisions of the spine and how many bones are in each, such as the cervical has 7, the thoracic has 12, the lumbar has 5, the sacral has 5, and the coccygeal has 4. 7, 12, 5, 5, and 4, 33 bones total. You should probably know that for the lab, actually. You can probably have that memorized by then. You should be able to find the sternum. I don't really care about the manubrium, which is the superior aspect of the sternum, so we're just going with sternum. Ribs, know how many ribs there are. Intercostal muscles, the muscles in between the ribs, and understand where the diaphragm is located and what its main function is. On the shoulder and upper extremities, we're looking for scapula, clavicle, humerus, olecranon, which is your elbow, the radius, and the ulna, and you can tell which one you're touching, the radius on the thumb side. Carpals, metacarpals, and phalanges. You'll also notice in the lower extremities, your toes are also called phalanges. So your fingers are phalanges and so are your toes. The bones are. On the pelvis and lower extremities, the iliac crests, the ischial tuberosities, the femur, patella, tibia, fibula, tarsals, metatarsals, the calcaneus, your heel bone, and then again the phalanges. So start looking at that. Look in your book. There's great diagrams. Look it up on the internet. There's great diagrams. And start learning those bones by putting on diagrams or just touching a bone on your body or somebody else's with their permission, of course. Maybe you use Post-it notes. There's all kinds of ways to learn this, and you ought to really get going on that. And a fair amount of your time in independent prep for this lesson should involve the bony anatomy. So assessment of the musculoskeletal system, we look for pain to palpation. Palpation means when you touch it. Palpation or movement. Crepitus is the sound that's heard when bones are broken and there is a grinding sound. And unfortunately, I don't really know how to describe that, but you'll know it when you hear it as long as you're listening for it. We're going to look for swelling, look for deformities, and then remember that we're symmetrical by design. Our right leg should look more or less like our left leg. Now, my right leg may not look like your right leg, but my right leg kind of looks like my left leg. And so that's pretty much what we're talking there. And symmetry is normal, and it's helpful because in many cases they'll have an injury on one side but not on the other. You need to know what distal CMS means. Distal, meaning away from the heart, and we use CMS. Now you'll hear some people say PMS, meaning pulses, motor and sensation. We think PMS is something entirely different, and we think that circulation, CMS, is what's right because you can't always find a pulse. So take your finger, for example, the tip of your index finger. We can assess your circulation, but we can't really find a pulse in the tip of your index finger. But we could assess the circulation by measuring or assessing, comparing skin color, skin temperature, how fast your capillaries refill when we squeeze it and it blanches out and you let up, how fast that capillary refill occurs. So we can assess circulation without the use of pulses, and so we think it is CMS, not PMS. Motor function means the ability to move it. Sensation means can you feel us when we touch it. So consider a guy with an injury to his tibia, which is a bone in the lower leg. We would want to check out his foot and see if the foot on the injured leg has the same skin color, skin temperature, and cap refill as the foot on the non-injured leg. We'd want to know if he can move the injured leg's foot the same as he can the non-injured one, and if he has sensation there. So distal CMS is a key concept in terms of managing problems in the musculoskeletal system. What are we trying to accomplish here? Well, we're trying to limit pain and limit internal bleeding. Both of those things. We're trying to prevent movement of the injury so that it doesn't make it worse. It's kind of a bad sentence. If we can limit the movement of the injured area, we can limit the ongoing injury that's occurring to that area. Normally, you're going to splint the extremity however you find it. Splint it as it lies. If there is normal or reasonable distal CMS, there's no reason for us to try to straighten things or move them around. If something is very deformed and angulated, then we may want to return that toward anatomical position, toward normal position, in an attempt to improve distal CMS. That would be the best plan. We want to avoid any of our splinting making that distal CMS any worse. So again, distal CMS, key concept, and here's where it fits in. If there's a joint injury, let's say an elbow or a wrist or a knee, any joint that's injured, we want to evaluate distal CMS. We're probably not going to do any manipulation even if distal CMS is pretty compromised. We want to splint that long bone above the injury, above the injured joint, and splint the long bone below the injured joint, and then recheck distal CMS to make sure that our splinting didn't make things any worse. The patient shouldn't be any worse off because we showed up. So this is the general management plan for a joint injury, and we would expect you to know this and prove that you know this on the readiness check for lab. We can't really move you into a lab setting where you start dealing with joint injuries if you can't tell us these basics. Check distal CMS, splint the long bone above, splint the long bone below, recheck distal CMS. I think you ought to be able to have that down before you come to lab. Long bone injury, fairly similar. We're going to evaluate distal CMS. We're going to splint the joint above the injury and the joint below the injury, and then recheck distal CMS. The only thing we might add in here is that it's reasonable to attempt to return an injured long bone toward a more normal anatomical position if that distal CMS is really bad. But in most cases, we're going to splint it like it lies, check distal CMS, splint the joint above, splint the joint below, recheck distal CMS. When you go take your EMT National Registry Psychomotor Skills exam, one of the skills you may have to do is long bone injury splinting. One of the skills you may have to do is joint injury splinting. So you should be really good at these. You should never have any problems with these, and you really want to get these on your registry test because they're really easy. Your general splinting plan is the B's of splinting. You can make a board splint. You can have a buddy splint where you like splint fingers to fingers or toes to toes. You can do a body splint. Maybe if the arm is injured, you can secure it to the body. Or if one leg is injured, you can secure that to the body or to a board. You may be able to use splints that you buy, like a vacuum splint or a traction splint. You may be able to build up a splint. Maybe you want to use the SAM splint, which is a very cool tool that comes in a roll, and it's very flexible until you put a specific bend in it, and then it becomes rigid. So we'll teach you SAM splints in lab, and there's some stuff in your resource document about SAM splints. And you may do that general splinting with a board splint or buddy splint or body splint, or you bought a splint or you built a splint And then we're going to add the sling and swath. And sling and swath is a key thing for you to know for upper extremity, and a backboard or ambulance cot or cart for lower extremity. So talk about kind of specific areas here. Fingers, pretty good to buddy splint those. Maybe the hand and wrist, you could make a board splint plus a sling and swath, maybe. Maybe not necessary if it's just a hand or a wrist, but doesn't hurt. If it's a forearm or elbow or upper arm, you definitely want a board splint and you definitely want a sling and swath. If it's a shoulder or clavicle, you definitely want a sling and swath. So we had sling and swath involved in 2 or 3 of those, and we had board splints or rigid splints involved in 3 of those. And so you can see where the ability to make a rigid splint and then supplement that with a sling and swath would be key, and that should be what you're looking for upper extremity. On the readiness check for lab, we would expect you to be able to answer a question about, for in general, an upper extremity splint would get what? And you would say, well, it would get a rigid splint of some kind and a sling and swath. The hip, one of the more frequently injured areas in falls, and realize that there isn't a hip bone. It's an area. It involves the pelvis. It involves the proximal femur, meaning the opposite of distal, proximal meaning closer to the heart, a proximal femur. And these patients are in pain. Now, they've usually put themselves in their position of least discomfort, but they're still hurting, and any movement hurts them a lot. And so we'll probably secure that patient in a recumbent position, which means laying down on their side probably, and we'll use a spine board, we'll use a scoop stretcher, we'll use a soft stretcher, we'll use a blanket, a direct lift. We have lots of options, and so you need to be familiar with how to do all of those sort of splinting tactics, and then you can make the good judgment that's needed to pick the right one at the right time. We are never, never, not one time ever going to use a traction splint on a hip fracture. A traction splint, we will show you in lab. You aren't tested on it by the National Registry. We want you to have some familiarity with a traction splint. But we really expect you to say, and you should say this when you come to lab, that if the pelvis is not intact, the traction splint shall not be used. Well, since the hip injury, possible hip fracture, by definition involves the pelvis, then it would be absolutely ridiculous, wrong, evil, mean, and it should be against the law to use a traction splint on a hip fracture. On the lower extremities, you've got toes, which can nicely be taped to toes nearby. You have foot and ankle, which a good rigid splint would be good for. You have tib, fib, patella, board splints there, and then you have the femur, where board splints would be good. And in the case of an isolated mid-shaft femur fracture, you don't have hip involvement, you don't have knee involvement, you just have, very strangely, a mid-shaft femur that's fractured, and maybe some, who knows what the mechanism would be there, maybe a direct blunt impact just to the femur, maybe a rifle shot or something that shattered the bone mid-shaft, something, then you might be able to use that traction splint. But you know what? If you went through your life never using traction splints, it would be an okay thing. So we want to show them to you because they're out there, and there's some folks that are in love with them for some reason. But prior to an x-ray, to make sure that there's not involvement of the femur, of the pelvis, prior to an x-ray, to rule out involvement of the pelvis, we can't be pushing off the pelvis with a traction splint. So anyway, lower extremities would be a rigid board splint and a spine board or a scoop or a soft stretcher or a blanket or a direct lift or an ambulance cart or whatever. So you should come into lab knowing that upper extremities get a rigid splint and sling and swath, lower extremities get a board splint and then a spine board or scoop or some other adjunct to that. So here's the summary. It's a pretty short one. Here's the summary. Why do we manage, or what is our goal in managing musculoskeletal system injuries? Well, your musculoskeletal system provides you protection and allows for movement, but when it's disrupted, There can be internal bleeding from the injured bones and very painful movement. So we want to limit the bleeding, limit the pain, limit that movement. Don't make distal CMS any worse than when we showed up, and just manage these injuries with the overall priorities. The sicker the patient, the more basic the splint should be. Your very sickest patient who has everything broken in their body except their earlobe maybe should be on a spine board for splinting all of that. You don't want to take the time to make each individual splint. So the very, very best splint for any given injury is based on the patient's condition. How sick are they? The sicker they are, the simpler the splint. Upper extremities, get a board splint plus a sling and swath. Lower extremities, get a board splint plus a backboard or cart or something like that. So that's really it. And you should really do well on the readiness check for lab on this one, because there's just not that much to it. Be sure you know distal, CMS, and know the general plan, and we'll see you in lab.